All right, hello and welcome everyone to our latest event in the precision medicine and solid tumors event space. Thank you for tuning into this talk. We look forward to bringing you more presentations in this space in the upcoming months. Today, our speaker is Dr. Francisco La Rosa from the University of Colorado, who will be discussing navigating renal tumor pathology, insights and innovations. So here's a look at today's agenda. My name is Ian Moore, and I'm a lab relations manager with Diagnostics. I'll provide a short background about Diagnostics as a whole, as well as DXRX, our precision medicine platform for labs. I'll then turn it over to Dr. La Rosa for his presentation. And at the end of the presentation, we'll dedicate some time for Q&A, where we'll be able to answer your questions. Please note, you can ask questions at any time during the talk by typing them in the box below this presentation. Diagnostics is an end-to-end services provider and data analytics company specializing in precision medicine. Our mission is better testing, better treatment, and we are building towards a future where the testing ecosystem allows all patients to receive the right treatments at the right time. We believe that labs need to be involved earlier in the precision medicine decision-making process. We have experience in 96 disease pathways and have worked on every precision medicine brought to market with 36 of the top 40 pharma clients, and we have a global presence across 53 countries. All diagnostic labs can find a benefit from a DXRX registration, regardless of shape or size, and we see this collaboration having a positive patient impact all over the globe. Our goal is to break down global barriers between labs, and we see DXRX as the way to accomplish this. A DXRX lab membership enables you to be the first to hear about exciting sponsored scientific studies and DXRX collaborations, be part of our data-driven recommendations to increase your visibility to precision medicine stakeholders, as well as access to lab talks and lab webinar recordings, precision medicine reports, biomarker reports, and DXRX live newsletters. On both the left side of the screen and in the DXRX booth in the exhibit hall, you'll find a link where you can schedule a meeting with a lab relations manager to learn more about DXRX and joining our lab network. We'd love to meet with you. It is now my pleasure to introduce Dr. Francisco La Rosa. So Dr. La Rosa serves as an associate professor in the Department of Pathology at the University of Colorado Anschutz Medical Campus and is a distinguished member of the University of Colorado Cancer Center. He originally graduated as an MD in Lima, Peru, with a residency in clinical pathology, followed by residency in anatomic and clinical pathology at the University of Colorado. He is board certified in anatomic and clinical pathology and specializes in genitourinary, renal, and heart pathology. And he's recognized as an expert in pathology informatics as well. Dr. La Rosa actively engages in clinical practice, research, and education with over 100 publications in referee journals. Thank you for joining us today, Dr. La Rosa. We're really excited to have you here. And with that, I will hand things off to you.
Well, thank you very much, Ian. It's very an honor to be presenting this webinar and with a selected audience. And I want to emphasize that the level of the complexity of this presentation, I had to tune it up between people who are not very familiar with the pathology of renal cell tumors and with pathologists that have general practice. At the end of the presentation, I'm going to provide you some references that you can access in case that you want to go deeper into the aspects of my presentation today. So without more details, I just want to mention that the presentation is just a comprehensive exploration of the latest advances in the pathology of renal tumors in adults. And that's very important because I'm not going to refer to pathology in children. That is a completely different aspect and also a specialty. And we are going to focus in most recent developments in the classification of the renal tumors, the histopathological diagnosis, and especially the main challenges and the emerging trends in this field. So the learning objectives are outlined here. I hope that you can gain insights into the classification of these tumors especially in the subtyping. And especially, I want to give you kind of a panoramic idea of how the concept of classification of the renal tumor has evolved during the years since the 2 centuries ago. We want to understand the different challenges associated with these different malignancies and explore the special stains or molecular testing that we can provide, as well as discuss the different trends in the approaches for this diagnosis of renal tumors, including the evaluation of the great heterogeneity of this pathology, and then especially the implications that they have in the decision making, especially for the clinicians. Pathologists are going to basically provide the clinicians the specific diagnosis, in which the oncologists mainly are going to, and also the surgeons, are going to elaborate the specific treatment for the patients. And if we made a mistake as pathologists, that is always an aspect that I remind to our residents and students, is that if the clinicians or the oncologists or surgeons make a mistake in regards to the treatment that they are going to give to the patient because of the wrong diagnosis provided by the pathologist, they're going to say, well, the pathologist told me. And then the liability is going to reside on us, not in the attendings that are taking care of these patients. So this is a very kind of an important point to emphasize, that the importance of the pathology diagnosis in these cases, not only in renal pathology, but in general for all the cases that we have to get involved in diagnosis. Well, this is just a basic introduction of the anatomy. I'm not going to go into detail, but the kidney is a very important organ. And what is interesting is that we have 2 kidneys. And it's very interesting that you can remove 1 kidney. That means remove 50% of the function, of the renal function in our body. And the other kidney by itself can take over the 100% needs in regards to the renal function. And that's why it's relatively common right now that we can donate our kidneys. Live donors can provide their kidneys in cases of relatives or other individuals that are closer to us, and provide this kind of a saving advantage that we have in the transplantation specialty. The nephron, we're going to see some details. And the most important thing is that the glomerulus here is basically a bundle of blood vessels. And most of the tumors that are going to be presented today, they are not related with the glomerulus. The glomerulus, basically, there are no very well-defined tumors that are going to be starting from this area, and also, unless that they are an angio or carcinoma or something like that, that is extremely rare. Most of the pathology, probably more than 99% of the pathology that we're going to see in renal tumors, are going to come from the tubules, from the proximal and the distal tubules, and because they have epithelial cells. And most of the tumors in pathology are derived from the epithelial origin. And this is cells that are constantly dividing. And this is a histological image where we have the glomerulus in the center. But here, these tubules that are sectioned, remember always that this is a 3-dimensional image, specimen with a 2-dimensional image, in which we need to use what is called a 3D reconstruction in our brain to have an idea how these elements are arrayed in regards to each other. The most proximal tubules are depicted here. They are larger, with a larger amount of cytoplasm, versus the distal tubules, in which the cells are smaller, the diameter are smaller as well. And the presence of blood here is just an artifact, because the tubules, they shouldn't have any blood inside. But anyway, after that, I just want to give you a panoramic view of how, since the 1800s, the classification of renal tumors was the of interest for physicians. And the first one, 1826, this is before the use of the microscope. The microscope started at the late 1800s. So in 1826, they didn't have a microscope. They basically made the diagnosis of these tumors based on the morphology, on the gross appearance. And as you can see here, fungoid, they look like fungi. Medullary were in the inner part of the kidney, cirrhosis when they were very hard, and steatomatous when they were fatty. So quite a very, very simple classification. And during this next 15 years, additional cases were accumulated by this Dr. Miriel, who was a pathologist. And then later on, in the late 1800s, with the advent of the microscope, Dr. Grauwitz from Germany, at that time, the German medicine, it was basically the leader in the world. And this doctor was able to look at the microscope, but he didn't have any photographic cameras at that time. There was no any kind of adaptation of the so primitive photographic cameras. So they had to rely just in drawings. And this is just one of the drawings that he had of an intrarenal adrenal rest, he called it. They thought that these were remnants of the adrenal gland. Basically, today we are identifying these like small nephromas, that they are just benign tumors of the kidney. But anyway, it's very interesting, the correlation, how this is started to evolve. Then we have to wait until 1975, when the Armed Forces Institute of Pathology, they started to see this great variety of tumors, and they were able to provide the first classification that is recorded into clear cell carcinomas, papillaries, chromophobes, and collecting ducts. This classification gave the first framework for pathologists to be able to make some differentiation in these tumors. Then in 1982, Dr. Furman, also a German, noticed that based on the morphology of these tumors, especially the clear cell carcinomas, and he published this in 1982, this is the prognostic significance of morphologic parameters in renal cell carcinoma. He noticed that the shape of the nuclei of the tumor had correlation with the life expectancy, with the prognosis of these tumors on these patients. So he was able to classify these tumors in 4 different grades. That was the famous Furman nuclear grading, in which you can see here better in graphics. The Furman grade 1 were tumors that had a very small nucleus with no evidence of nucleoli. And in this particular case, this tumor is an interesting finding, that this tumor in this area had one area with the Furman grade 1, and this area with the Furman grade 2, in which you can start seeing the small nucleoli. Then in the Furman grade 3, the nucleoli are more distinct. You can even see them with a low power magnification with a 10x objective in the microscope. And then the Furman grade 4 was with the very overt polymorphism with cells that are with more than one nucleus. And in this one here, it has 3. Very significant disarray of the tumor, and the very amorphic and very large tumor morphology. And finally, within the Furman grade 4, he also mentioned the presence of what is called sarcomatoid feature. As you can see here, as comparing this Furman grade 4 with the original ones, the tumor already lost any kind of identity with what is normally seen in other less aggressive tumors. And in this case, they have the shape of sarcomas, and that's why they're called sarcomatoid. And just to give you an idea of the work so significant that he had, this was a breakthrough in the classification of tumors. This nuclear grading helped tremendously in the evolution of these patients and in the prognosis of these patients. At that time, there was no grading or staging that we usually have for the tumors in general, but just because of the grading, look at the survival. If the tumors were grade 1, this patient had more than 10 years survival, but according to the increased changes in morphology, grades 2, 3, or 4, the life expectancy of these individuals was lower and lower. And as I mentioned before, was just a breakthrough in the classification of these tumors. And it was until 1986 that this Dr. Wolfgang Kronz, also in Germany, in Mainz, together with his colleagues, were the first ones to put a little bit of more order, and it were the first one to correlate the origin of the tumors with the classifications that were proposed in previous years. For example, the clear cell carcinomas, he demonstrated they come from the proximal tubular nephron, whereas the chromophilic cell carcinoma comes from the end of the proximal tubule. The chromophobe comes from the area of the more distal tubule as well as the oncocytoma. And then in the areas of the ductal, when the urine is collected, that is more central in the medulla of the kidney, we have the duct of Bellini carcinomas that were being described at that time, with the different morphologies that were already established by Dr. Furman in the previous years. So this was also another breakthrough, and his classification was only simplified following the previous classification from the Armed Forces Institute of Pathology in the United States in clear cell papillary chromophobe collecting dark carcinoma, and then he included an item that was the unclassified RCCs because they were not they didn't fit in any one of the classifications. And nowadays you can see the tumors in the kidneys are very heterogeneous, and then people started to get so confused. They didn't have the same prognosis. Some people will have a very good 10-year survival, and others individuals will develop metastases. So this had to be read in a very more scientific way, not only depending on the pathologies, but also oncologists, surgeons, etc. And the first classification really that put together all these brains was in 2004 in Lyon, France, with this group of very nice-looking people that got together in a very nice resort, of nice environment, nice dinners, and etc., and they were able to bring all their data to produce the first classification of the World Health Organization of the renal cell tumors, in which they included, in addition to the conventional previous tumors that were already described, the first time that a molecular classification, the XP11 translocation carcinoma, that was very similar to these other tumors, but they were able to identify them for molecular studies and were included in this classification. And in the first group of carcinomas, they were in different degrees of aggressiveness, being the clear cell carcinoma always the most dangerous one, and also the renal medullary carcinoma, some of them. But there was not a very stable classification. And then we were able to identify some other tumors that were basically benign, like papillary adenomas and oncocytomas. And it took until 2016, in which the WHO got together again, and then in addition to the renal tumors that were classified, and they extended the classification, like for example, MIT family translocation, the succinate dehydrogenase, etc., with some molecular classification were included, in addition to other tumors that were not necessarily primarily from the nephron, but they were coming also from the fat, from the vessels, etc., together with the basically renal cell tumors. And then pathologists and oncologists were able to realize that not all the clear cell carcinomas, for example, that were the most common, are the same. Here you can have two tumors that look basically identical in regards to the clearing of the cytoplasm and the size of the nucleus, etc. But when they were able to do some molecular analysis, they were completely different tumors with completely different evolution, risk for the patient, etc., etc. Like, for example, the translocation of the HB11.2 that is positive for a marker that is the TFE3 in the nucleus, renal cell carcinoma. So both are clear cells, but this one it has different kind of behavior in the patient, and also not only that, but the most important thing that there were different sensitivities to chemotherapy, and that is extremely important for the evolution of these patients. So now we have the final classification in 2022 that is called the fifth edition from all the other previous ones, in which you can compare the classification of the 2016 with the 2022 with the most important inclusion of what is called the molecularly defined renal carcinomas. These tumors, they look mostly identical to the previous tumors. There are several tumors that are clear cell here that are very similar to the clear cell carcinoma conventional one, but that it has completely different molecular makeup. And the evolution and the treatment also is going to be different. So there are also papillary tumors that were very similar to these ones here, but the molecular makeup was making them different. So the new classification that is now evolving, because from between 2022 and now, there are already some new comers, tumors that are being identified. They are very rare, but still that they have differentiations that make them particularly with specific diagnosis. So we continue with the clear cell carcinoma that was observed from the very beginning, and then with papillary renal cell carcinomas as well, oncocytic carcinomas collecting ducts, but with several most important differentiations, and then a group of tumors that are called other renal cell tumors that are mixtures of clear cells with papillary or tubulocystic, etc., that have also a subgroup of molecular defined renal cancers that we will analyze in the next slides. So this is just kind of a summary. Look, since 1975, even before with the previous observations in the 1800s that are not included here, this is taken from this article in Pathologica, we can see that the types of tumors that were originally identified or classified were just very few as compared with the new classification in 2022, in which we have all other different kinds of tumors classified by histology alone, and then a very significant number of tumors that are classified from their molecular characteristics. And then we are going to continue this classification in the future with the addition of new tumors based on the research that people are doing over these years. So the major updates in 2022 is that the many tumors are molecularly defined, and then we have a subgroup that I mentioned before that is called other renal cell carcinomas, basically here, that are less common, definitely. And one of the reasons that we have these other renal cell tumors is because now we are in increased number of publications defining those tumors and making the differentiations in the molecular, the histological aspects, etc., that are being included. These other renal cell tumors, fortunately and unfortunately, they are just a few cases in the literature. Some of these cases, there are only 30 tumors described, and in some others, there are 40 or 50. So there is still a very small number of tumors comparing with the millions of tumors that are being diagnosed over the world with the clear cell carcinoma or papillaris, the original tumors that we discussed at the very beginning. Now there are 3 new renal cell carcinomas definitions have been defined, and then the papillary renal cell carcinoma in the past, it was being identified like type 1 and type 2 being type 1, a more benign form, and type 2, a very malignant form, because they look different and they look more ugly. But then when they start to study these statistics, it seems that both 1 and 2 types of papillary carcinomas, they became identical. So there is no reason to make this differentiation, because at the end, and there is no way to really make a prognosis of which one is going to be more aggressive than the other. So they have exactly the same morbidity at the end. The type 1, even though they look benign under the microscope, they may behave malignant, versus the type 2 that they may be look under the microscope very aggressive, but then they are not, they are also benign. So this is a very important step in this classification. So other minor updates that have been presented in this classification is these new emerging entities that are being studied now with more sophisticated analysis and the identification of specific markers that can be, in many cases, very important because can be family related. And if there is family relationship with those tumors, it's important not only to make diagnosis in the patient, but also in the relatives, so they can prevent these tumors to become too big, and then the consequences of metastasis, etc. So the earlier the diagnosis in this individual is also going to be life-saving issue. Anyway, so the subtypes of the papillary renal cell carcinomas that are now being classified based on their molecular levels, and then there was this terminology. Sometimes this creates a lot of discussions. Why do you call it unclassified, or call it not otherwise specified? So they decided just a kind of a terminology. Now, if we don't know what the tumor is, we just call it NOS, and then we had to send it to some other centers with better conditions in the laboratory to be able to identify molecular aspects of these tumors. That sometimes can be done, sometimes they, at the end, they're basically unclassified or NOS. And then there was some change in terminology of this kind of a tumor that was called hereditary leiomyomatosis associated renal cell carcinoma, because they were associated to these morphological aspects of the leiomyomas that are present in these patients. They have a genetic defect that is basically in the fumarate hydratase, or the FH marker, that is missing in these patients with leiomyomatosis, and they are also susceptible to have these renal tumors. And then there are some discussions in regards to grading, for example, of the chromophobe or oncocytic tumors, that is, we're just waiting more data to be able to make a better classification and so of the emerging entities that are listed here. So these tumors, I'm going to present them from the academic point of view, but since they are so rare, for example, the eosinophilic solid and cystic renal cell carcinoma, I think there are only 50 in the literature. The anaplastic lymphoma is mostly in children, but it's also present in adults. There are also, I think, like 30 or 40 described. The mutated renal cell carcinomas, previously named TCAB1, now it's called eosinophilic low malignant potential oncocytic carcinoma, or some of the other low-grade oncocytic tumors, and the what is called eosinophilic vacuolated tumor, that I think there are only 10 or 20 in the literature. Anyway, these emergent entities, they require additional research, and they are the ones probably they are going to be included in the next classifications next time that the WHO considers appropriate to get together. And I'm not going to go into more details about these tumors because, as I said before, they are more rare. So let's go to the more common. So the renal cell carcinoma clear cell type, the typical one, the classic one, is the most common of all the renal tumors in adults. And then you're going to see these different kinds of tumors arising in the medulla, in the cortical area, not in the medulla, but they have different aspects in the gross examination. They usually have this kind of variegated morphology with areas of hemorrhage mixed with areas of solid tumor and different colors. And then sometimes they can have polycystic morphology, as you can see here, especially in patients that have chronic dialysis for some reason. The tumors that are developed in the native kidney of these patients, because they are already atrophic, these patients have the propensity to develop these cystic adenocarcinomas of the clear cells. With the advent of the imaging analysis, you can see the statistics of renal cell tumors has increased progressively since the time that the CT scans were invented. And you can see that most of the tumors that now we are doing surgeries are because incidental findings. The person, for example, has a backache. They think that it's a problem in the spinal column, that they probably osteoarthritis or some other related tumor pathology. And then by doing this kind of examination, they say, oh, look at its kidney. The kidney has a tumor. So go to surgery. So the incidence of this tumor has increased tremendously. And unfortunately, and this is a very sensitive subject, the incidence of these tumors has increased mostly in the obese population. In our country, I even have problems sometimes talking about obesity with my students, that they are considering me kind of politically incorrect because I'm talking about obesity. But obesity is a disease. We have to acknowledge that. And the incidence of all diseases are increased in the obese individual. And these pathologies have a very close correlation. The more pounds an individual has overweight or obesity, the shorter the lifespan. It's been demonstrated in many papers, and especially in individuals that have tumors. And tumor incidence in regards to kidney as well is extremely higher in individuals with obesity. And I cannot tell you without exaggeration, being in Denver, Colorado, that Colorado is one of the states that it has the lowest index in obesity. Almost 40%, without exaggeration, almost 40% of the tumors of the kidney that we examine here are related in people who have a BMI over 30. So that is a different degrees of obesity. Anyway, so here you can see that this tumor, this is a reference. Remember, this is the left side. If this is your right side, is the left side in the CT scan, and this will be the right side. If you compare this kidney with this other one, this is significantly larger. And then it has this area protruding out of the kidney that is a thrombus into the renal vein, that it can connect with the inferior vena cava and then even migrate to the superior vena cava. And those are going to be elements that are very important in the staging of this tumor. This is a different kind of incidence. The other one was a cross examination of the abdomen. This is the liver. Here the kidneys, vertebra, etc. This is the posterior aspect of the patient, the anterior aspect of the patient. And then here we have a anterior-posterior view where we can see the normal kidney here in the left side, and then the right kidney, the same one that we saw before, with this thrombus, that is a tumor that is migrating inside the vein into the renal vein and then into the vena cava. These are pictures provided by Dr. David Crawford. He's been my mentor during many years, and I have to always recognize his influencing my vocation as a pathologist, providing me these pictures of this exactly the same patient. These tumors that you see here are being seen in the operatory field, like a very large kind of a sausage-like increase in size of this renal vein that is very obvious. And then he was able to cut that renal vein to be able to release the tumor. And this particular tumor was not adhered to the vein wall. And that is something very important to consider. Sometimes these tumors are invading the vein, but they are, some other cases, just like in a thrombus that you can remove to conserve the vasculature, especially the inferior vena cava. These are other kind of renal cell carcinomas that they have also thrombosis with a dilated renal vein. This is a big sausage as well. This is the way that it's being sent to our pathology practice. And these, all the previous ones were renal cell carcinomas. Now these are papillary renal cell carcinomas that in the familiar cases, when the patient has a family trait where there is a specific mutation of genes that we're going to see later, if they have the family predisposition, usually these tumors are multifocal. This is usually in earlier ages. These patients can develop these kind of tumors, and sometimes they are bilateral, and they have to remove both kidneys and go into transplantation. Whereas the clear cell carcinomas can also have a similar appearance of multifocal presence when the patient has a family trait or a genetic trait in contrast to the tumors that is present in older ages. When individual has a tumor, either renal, clear cell, or papillary, at the older ages, they are usually mutations that are acquired with radiation or substances that we eat, etc., that are going to produce mutations in this. So these are acquired mutations, and those tumors are present in late ages. When these tumors, like this one, for example, is multifocal, they are, and also in earlier ages, they are mostly related with a genetic trait. This is just to show you, for example, in the case of the papillary carcinomas, that they are this, as I mentioned in previous slide, it's not mentioned here. I think I missed that one. But then this is the second most common. This is the second most common renal cell carcinoma, and they have this papillary appearance in contrast to the more homogeneous presence of the clear cell carcinoma. And the papillary features are these prolongations that they look, and they're, when they are not in a section, this is just, they look like a fenestrated or a papillary projection with a lot of arms and with a core that is, these cells that are lighter, these are macrophages. And also the vascular components are in the center of this papilla. And then the tumor itself is the cells that are surrounding this papilla. And this case, because of the bland presentation and the very typical papillary morphology, we call them in the past type 1 tumors. There were about 70% of the cases. And the ones that didn't have this nice morphology, they were more haphazard. They have larger nuclei and also crowded nuclei. They were like what we call pseudostratification of the nuclei. This was identified as a more aggressive tumor, and we call it a type 2. But as I mentioned before, in the new classification, we were able to study the statistics of these two tumors, type 1 and type 2, and the survival is exactly the same for both of them. It's about the statisticians have defined that there is not a significant difference between them. So now as pathologists, we don't care if it is this shape or this shape. We just call it papillary renal cell carcinoma without having to classify the aggressiveness. Now, genetics is very important. The clear cell type, the most important variation is the mutations in the von Hippel-Lindau gene of VHL that is in the chromosome 3. And then this gene that is present, we can identify it, and the deletion, we have genes, always one pair of genes, one from mom and the other from your father. So in most cases, there is a deletion of one of those genes. Or other times, there is a translocation of these genes in other chromosomes, or sometimes the somatic mutation of hypermethylation that is also present in almost 80% of these renal cell carcinomas. Now, the sporadic ones are the ones that are present in later ages, that is almost 95%, and the familiar is only in 4% of the cases. So these individuals that have the familial, they have this syndrome that is not only the multiple renal cell carcinomas clear cell type, but also they are bilateral, as I mentioned before. They can be several tumors in the same kidney, or glioblastoma in the cerebellum and retina. The genetics of the papillary is similar. There is also not associated with the same deletions as in the previous one, but it's a trisomy of number 7 that is the familial form. But this locus is also present, is related with the tyrosine kinase receptor that are related with the presence of this tumor. So the morphological appearance is also related with differences in the genetic background of these tumors. We can have sporadic ones that are usually unifocal, or hereditary that are multifocal or bilateral, but they are basically related with the same kind of mutation, as well in the case of the clear cell carcinomas, that it has exactly the same kind of loss of the VHL gene, but in the sporadic forms, in aging older people, they are most likely unifocal, whereas the hereditary clear cell is in earlier ages and multifocal or bilateral. Then we have another set of tumors, we call them oncocytomas. The most important feature is that their cells are very heavy in the amount of mitochondria that give them a specific appearance. They are approximately 5% of the renal neoplasms, and they are identified under a microscope for this kind of rounded, very generous amount of cytoplasm with this kind of granular appearance due to the mitochondria. If you see this under an electron microscope, they are loaded with mitochondria, and some of them, they have this kind of racing-like nuclei that are very typical of the chromophobe. This is in contrast with another oncocytic tumor that looks very similar even in the gross examination, with this kind of a central scar, but in this case, the morphology of the nuclei is more homogeneous. They don't have this kind of racing-like. Sometimes they can have some little heterogeneity, but then we can use special stains either from the immunohistochemical side of battery of tools in the laboratory, or the one that is just a histochemical staining that is called the Hales colloidal iron staining. That's very typical to be positive in cases of chromophobe and negative in cases of oncocytoma. So anyway, going back to the classification of WHO 2022, here we have just a summary of the renal tumors and the most important differences between the classification in 2016 and the new classification. I'm not going to, you're going to review this video later on, but I just wanted to mention that there are some differences in the criteria. For example, in the case of papillary, they used to have the 1 and 2 classifications, whereas now we just call them papillary renal cell carcinomas, and we don't need to make any difference in the grading of the tumor. And so on with some other tumors identified by molecular factors that, in the case of the ALK or ALK, rearranged renal cell carcinoma in 2016 was just kind of an emerging entity, but then now with the new number of cases that are being identified, now is being included in the category of the molecular defined renal cell carcinomas. These are also they mentioned more details in the changes. That the previous one was just basically comparing the two classifications in 2016 and 2022, but now these are just a little bit more defined specific markers in the molecular background. Now, it's important to mention that or remark many of these tumors are being included in the classification because of the new number of cases being identified, but many of them, there are no more than 30 to 50 cases described in the literature. So if you find something similar, you don't think about the presence of these tumors as a possibility that can be confused with the previous cases, it's better to think about them and try to make a more specific identification. And if we don't have in the laboratory specific markers, send them to a reference lab for a better classification, because especially in cases that clear cell carcinoma, that they may look very similar, that they may hide their molecular, different kinds of molecular background. This is one of the tumors that has been reclassified, that was called basically papillary renal cell carcinoma. Now we call it clear cell tubulopapillary tumor, that it could be papillary, cystic, tubulocystic, et cetera. And then the most important characteristic is that they have this kind of papillas that they can be very simple or very complex. And one of the important differentiations with other kinds of renal cell tumors is that these tumors are positive for cytokeratin 7. For example, the clear cell carcinoma that is the most common in this particular case, that as you can see, they also is a clear cell. And so this is what produce some confusion, that this is a clear cell, but it has a papillary morphology. So these are, in contrast to the clear cell typical, that they are cytokeratin 7 negative. These clear cell tubulopapillary tumor are positive for CK7. Now, the carbonic anhydrase 9 that is present in the normal or the conventional clear cell carcinoma is in all the cells, but in this case, it's just like a cup-like. And here in the other image, you can see that the difference between the carbonic anhydrase of the typical clear cell renal cell carcinoma is complete in the whole cell, whereas the clear cell tubulopapillary, they are both clear cells. The carbonic anhydrase 9, it has this cup-like morphology. The other difference is that the CK7 in the clear cell typical is negative, whereas the tubulopapillary tumor clear cell is positive. Also, the presence of CD10 is negative in the papillary tumor, whereas this should be CD10 in the clear cell carcinoma classical is positive. Now here you can also see that we can do some molecular analysis with this in vitro hybridization for identifying different kinds of genes. The renal cell carcinoma has the 3P deletion and is marked here in green. As I mentioned before, all genes, they had to be in pairs, like these two here that are based as a reference. But in this particular case, that the gene for 3P is identified with this green marker, there is only one. And that is the characteristics of the clear cell carcinoma. Whereas in this case, the 3P deletion is not present, and also the cytogenetics are completely different, like there is diploidy of the 3P in the so there's a normal presence of the 3P gene. And here you have also a very nice summary that the CK7, AMACAR, CD10, the TFE3, that is a tumor marker that is identifying other set of tumors that could be confusing, also is negative in both of them. And the carbonic anhydrase is positive in both of them, but with the clarification that the pattern of positivity is completely different. So if you are doing this kind of pathology, you can have a very nice reference in regards to the molecular makeup, not only the morphology, but the molecular makeup of those tumors, but for the more specific classification. Now here is just we're going into the more rare tumors, and this is the anaplastic lymphoma kinase ALK rearranged renal cell carcinoma that is associated with anaplastic lymphoma. This is typical in children, but it's also present in adults, and that's what I'm presenting it here. And also, you can also see that this gene with a tumor that is kind of tricky in the histological identification. In some areas, they can be papillary, and some areas can be very solid. So if you don't think about these tumors, it's going to be very difficult to identify them. Probably we could have called it just simply papillary renal cell carcinoma. But then we have now a special staining for the ALK rearranged expression. There's some proteins that are present in the cytoplasm, and this tumor is positive, confirming the presence of this diagnosis, the ALK rearranged renal cell carcinoma. Another tumor that has been incorporated in the new classification is this eosinophilic solid and cystic, and there is no need to explain why it is called solid and cystic. And this case is can be also confusing because this can be also misinterpreted as oncocytic tumor, either a chromophobe or an oncocytoma, but they also have different kind of molecular makeup, and also they are positive cytokeratin 20, etc. These tumors, it has a it has a very uncertain malignant potential. Some tumors produce metastases in the ones that are reported in literature, but as I mentioned before, there are not too many to be able to make specific considerations in regards to the prognosis of these tumors. I think there are only 40 or 50 in the literature. This is another form of this tumor in the close-up that you can see that also it has a very typical eosinophilic cytoplasm. They don't have a clear cell. They don't have a papillary morphology unless you find areas that may look a little bit papillary together with the cystic. But anyway, these are some of the variations that the expert pathology need to be considering when they examine these kind of tumors. This is another form of trying to identify. You can see here that this is the typical antigenic profile, that it has PAX8. This is a typical nuclear antigen present in all renal cell carcinomas and all renal cell tumors in general, the PAX8. So I can identify that from renal origin. That in this case is negative for CK7. The CD117, that's called KIT, is also negative, YAMACAR, etc. So we can start using these kind of patterns of recognition to be able to make specific differentiations with differential diagnosis, for example, with other tumors that may look similar, that are listed here as well, that they are rare as well, but that in the hands of more specialized renal pathology, they can be used as part of their set of antibodies or molecular studies that you can do in order to identify them. Finally, we have this other, it's another interesting tumor that it has this kind of fibromuscular bands, and this is called the ELOC mutated renal cell carcinoma that was identified in the past as a clear cell papillary renal cell carcinoma, but the presence of these bands of fibromuscular tissue makes them different as compared with the other tumors from the with clear cell morphology. So the tumors that are originated in the medulla, they are mostly corrected with the daxovelini, are nowadays in the new classification, uh, uh, they are called the SMART CBE1 deficient renal medullary cell carcinoma. And basically, this is a gene that is associated with specific markers uh, that, from the molecular point of view, they have some functions, but this gene is related with some special mechanisms of the metabolism of the cell, but in the particular uh, genetic anomaly in which this gene is not present, or is present but mutated, so they don't produce this particular substrate in the cell, then these individuals present these kind of tumors in the medulla. These are two examples in the literature of showing these tumors arising. In this particular case, it's very difficult to identify if it's originated in the cortex or in the medulla, but if this is basically started here, extending and protruding in the area of the renal cortex. This is more typical, located in the medulla, and they have also very polymorphic appearance. They look very aggressive. Sometimes they are not. They are associated sometimes with individuals with sickle cell anemia, and this association has been very interesting in the prognosis of tumors. Sometimes they are well to moderately differentiated, so the tumor has the tendency to resemble some tubules, or they are poorly differentiated, in which you don't know what these tumors are unless you start doing some specific stains to identify the origin of these tumors. Or they can have this sarcomatoid differentiation. These tumors, they require really a very detailed examination with immunostains and molecular markers, because if they don't have a very typical morphology, we don't know where to start. And sometimes with this kind of we had to throw the kitchen sink, that we call. So everything that we have in our arsenal in the laboratory is going to be used to try to identify them. This is a very interesting case of one of these individuals. This was a very famous uh, uh, basketball player. Was always first in everything, and then he had sickle cell anemia and developed one of these tumors. And the survival here at that time was basically zero. So he said, "Do I believe in miracles? Yeah, and I believe in Bradley." Was one of the comments. Then Bradley died anyway, but was the one who survived the longest. So the people who were their fans, they say, "Well, he died, but he was the one always is first to survive the longest in this particular disease." And then we have a bunch of other cases of tumors that they are unclassified, that basically they don't fit in any kind of the classification we have. And then we call them in the past unclassified, or nowadays in the new classification, not otherwise specified. Now, other tumors in the kidney, they can come also from the fat, from the neural system, muscle, smooth muscle, uh, neural system, fat, etc. And this is our star tumor in a patient who was an 80-year-old female, and then she has this large tumor that it turned out to be liposarcoma of the kidney, not originating in any other tissue of the normal kidney, like the tubules or blood vessels, but from the uh, uh, fat. So this is a liposarcoma, and it was just a big baby, 40 pounds, that this patient lost just after her nephrectomy. This was also a courtesy of this Dr. Chandra, who was the surgeon. Anyway, so what do we do with all this information? At the end, the pathologist has to provide a report with the analysis of the primary tumor, in which we are going to evaluate different factors, not only the diagnosis of the tumor, but also the size of the tumor, if the tumor has metastasis, either in the lymph nodes or in the distal metastasis in other organs. And these are just the elements that we have basically designed by the American Joint Committee of Cancer, the AJCC, and this is called the Tumor Nodes Metastasis System, or TNM, tumor and lymph nodes, and then metastasis. So based on the size of the tumor, we can classify, and the extension of the tumors. If the tumor, for example, is invading the renal vein, it has a higher grade than other tumors that are not invading the vein, or that they have smaller sizes. So all these things, as you will see before later, are going to have a correlation with the survival of the patients. And these are just illustrations provided by the American Journal of Surgical Pathology in regards to the location of the tumors. If the tumors are just located inside the kidney, or if they are affecting other organs. For example, if this is the kidney and this is the fat, we are going to evaluate the invasion of the capsule or the fat or the ureter, if it is in the renal vein or in vena cava or into adrenal gland. Each one of those elements are going to be considered in the evaluation. As you can see here, for example, metastasis is considered M1 if it is in the renal gland, or if the invasion is isolated, is M1. If it is just a continuation of a tumor in the kidney going into the adrenal gland, is just considered a PT4 that is lower than M1. If the tumor is invasion of the perirenal fat, it's called PT3A. This is some examples, so you can see the role of the pathologist. And then we combine the T, N, and M factors to provide these surgeons or the oncologists with the stage of the tumor. So depending on the stage, T1, 2, or 3, or 4, and depending on the metastasis in the lymph nodes or the metastasis in other organs, that we are going to establish the stages. And this is just the bottom line. I think that's where this is the last slide. How relevant is the disease-free survival based on, for example, the type of tumor? Chromophobes are very benign. People don't die after 100 months. But you have the papillary here, papillary tumor, they have some mortality. Clear cell carcinoma is either very significant mortality, and also the presence of sarcomatoid feature is really a very important factor of mortality in individuals. Most of them, they're going to die in the next 20 months. Now, in regards to the grade, nowadays we continue grading the tumors based on the Furman's classification, but now we remove the term Furman and we call it grade in the new classification. And you saw this in the previous slide. The grade 1s, they have longer survival as compared with tumors with a grade 4 nuclear morphology. The tumor diameter is important, and that's why all these things are considered in the staging. If the tumors are small, the survival is, this is the rate of metastasis, or the survival is very good, with very 5% of metastasis, whereas the tumor is larger than 6 to 7 centimeters, the possibility of metastasis is also almost 20%. And then the tumor stage, at the end, we have to have stage 1, 2, 3, or 4. We can see that the mortality in the stage 4 is very significant as compared with tumors with the stage 1. Thank you very much for your attention. And I want to invite you to scan this Q logo or go to this website. This is a video from Dr. Michelle Hirsch. She is an associate professor at Harvard University, a very close friend of mine. I have learned a lot from her. And I invited her to give pathology grand rounds in our university. And we use, I recorded all the presentation, but it's in a unlisted. So if you Google it, you're not going to find it. It's in my YouTube channel, Denver Pathology. You can also Google the channel with in YouTube. Just put Denver Pathology, and you're going to find my channel. But this one is just to access that specific presentation. That I think that is, if you are more interested going in deepness, in a deeper knowledge of these molecular features, she will have the answer. Thank you so much, Ian.
Yeah, thank you, Dr. La Rosa. Really enjoyed walking through not just the history of how we got here, but giving some clarification about the new guidelines. So no, really enjoyed that and really appreciate it. We'll follow up. We'll do a couple questions real fast in the interest of time. So the first question would be, how can labs best approach changes in WHO guidelines to ensure patients are receiving the best testing and treatment?
I think like in any other profession, you need to go to meetings, you need to read the literature, you need to be constantly updated. I had the opportunity to do some kind of a legal advices or consultations, and the main errors of pathologists are when they are not updated. So we need to have this presentation and the opportunity for me to share this knowledge. I think that I really appreciate it because my basic background is academic, and I really enjoy the area of education. And I think that the more that we can uh, expand this knowledge through this media, I think that that's one way to do it. So read articles, go to meetings, and keep in touch with all these new classifications. I think that that's the best way to do it. You're going to save lives, and you're going to provide better information to your colleagues, the oncologists and the surgeons.
Awesome. And then following up on that, so our last question would be, what recommendations do you have for labs of all shapes and sizes to ensure patients in various demographics have the same access to the critical testing?
Well, that's very difficult to have a more homogeneous recommendation because laboratories have different levels. In many laboratories, they don't do any kind of immunohistochemistry. In other laboratories, they do what is called the whole shamil, where you have the whole battery of immunostains and also molecular analysis. So you need to have a very good connection with laboratories in case that you don't do it in your house. You need to have a good center of reference. In my particular case, if I have a problem, I send it to Dr. Hirsch at Harvard. And sometimes, even if I remember that if I'm not 100% secure of my diagnosis, I need to have some help. I send it to another person for a second opinion, either inside our practice or outside. But especially in renal pathology, when I started to learn about these differentiations on the molecular level and the behavior of tumors that look the same under the microscope, that was terrifying. Because I started to see back in all the cases that I had been diagnosing, like renal cell carcinoma, probably the mutations are going to condition a completely different behavior. And if I had provided that information to the oncologist or the surgeon, probably this patient had a kind of different management. So I think that's important. That's important to have that connection. And if you are able to implement those new stains, yeah, you need to have, or at least if you have a laboratory with access to renal pathology, carbonic anhydrase 9, cytokeratin 7, even a pancytokeratin, PAX8, just to be able to confirm that the patient comes from the kidney. Not all the clear cell. We had a very interesting case. I don't know if I had time, but a patient had a tumor in the bone. And they did a biopsy, and it was a clear cell carcinoma. My colleague, pathologist, they call it clear cell renal cell carcinoma metastasis. He put the renal cell as a site of origin. When we presented this case in a tumor board, the patient didn't have any tumor in the kidney, but he had a PSA 20 nanogram per ml. The patient had a prostatic tumor, and then they did a biopsy, and part of the prostatic tumor looked like typical prostatic tumor. The other half looked clear cell. So if you see metastasis that they're like clear cell, it's very difficult to identify it as an origin unless you have those specific stains to make the differentiation. So I think that you have to have at least some basic stains for the most general thing, and then stains that you don't do it in a reference lab. So that would be my suggestion.
Yeah, thank you. Thank you for that. And thank you for answering both questions. And once again, thank you for taking the time to speak with us. We've all enjoyed it. And a big thank you to everyone in the audience as well. We'd love to speak with you about DXRX. So please check out the link to book a meeting. And we'll have more sessions in this event space in the coming months. So be on the lookout for those. We hope to see you there. And thank you again, Dr. La Rosa. And we hope everyone enjoys the rest of their day.
Thank you. Have a good day.